Hello, everyone, and welcome. Good morning to everyone west of Thunder Bay, and good afternoon to the east. Thank you so much for joining us on the first day of Canadian Patient Safety Week. My name is Christopher Thrall. I'm the Communications Officer with Canadian Patient Safety Institute, and I will be your MC for the webinar. I would like to welcome you on behalf of our webinar's technical host, CPSI Project Coordinator, Janet Bradshaw. This week is Canadian Patient Safety Week, and we encourage all Canadians to become involved in making patient safety a priority. CPSW's mantra is Ask, Listen, Talk, and our theme this year is Not All Meds Get Along. We're encouraging patients and healthcare professionals to start a conversation about the 5 questions to ask about your medications and increase awareness of medication safety issues. Of course, CPSW would not be possible without our generous sponsors at Gojo and Health Pro Procurement Services. We truly do appreciate their support. If you run into IT difficulties, or if you have any questions for any of our speakers today, including me, I guess, please connect with us in the chat or question and answer box, and we would be happy to assist. Today, our interactive medication safety webinar is moderated by Jignesh Padia from Patients for Patient Safety Canada. Jignesh was born and raised in India. He first moved to Canada in 2005 and has lived in both Scotland and England. He works for the Saskatchewan Cancer Agency and feels proud to have the opportunity to serve patients, families, and staff in improving safety and reducing risks in every possible way. Jignesh is a certified manager of operational excellence from American Society of Quality and a Lean Six Sigma black belt. Jignesh joined Patients for Patient Safety Canada in 2013. He also serves as a member on a local patient safety advisory committee with Regina Capel Health Region. His long-term dream is to work on a patient safety reporting kiosk where patients and visitors can report occurrences and near misses directly to their care team, creating more robust partnership and improvement in the health sector. Jignesh is a father of a 6-year-old boy, a husband, and a passionate patient safety advocate. And now, on to Jignesh himself for a few words.
Hi, everyone. Thank you, Christopher, for such a wonderful introduction. I'm hoping everybody is able to hear me. Hope you all had a lovely weekend. As Christopher mentioned, my name is Jignesh Padia, and I'm a member of Patients for Patient Safety Canada, which is a patient-led program. We are the voice of patient families, and caregivers. And we bring safety experiences to help improve patient safety at all levels in health system. This unique and valuable perspective complements those of care providers, health leaders, policymakers, and managers of healthcare organizations. By working in partnership, Patients for Patient Safety Canada helps ensure that patient safety decisions and initiatives are truly patient-centered and will result in safer care. Welcome to the Canadian Patient Safety Week's Not All Meds Get Along, Reducing Inappropriate Medication Use webinar. We have the privilege of Dr. Dee Mangin, Professor of Family Medicine and the Associate Chair and Director of Research in the Department of Family Medicine at McMaster University, and Sandra Hanna, a practicing pharmacist and Vice President for Pharmacy Affairs of the Neighbourhood Pharmacy Association of Canada, join us today to discuss medication risk, deprescribing, and the dangers of polypharmacy in this 1-hour webinar. Our first presenter is Dr. Dee Mangin, and I'll hand it over to Christopher.
Actually, how about we have Dee speak to start things off?
Hello, everybody, and thanks so much for the opportunity to talk to you all about my favourite topic, which is making medicine safer for older adults. As you can hear, I'm not from Canada originally. I'm from New Zealand, which is why I've got a bit of an accent, so I hope it's clear enough for you. One of my patients told me when I started practicing here as a family physician, she said, oh, not to worry that I just had irritable bowel syndrome. So I hope you can make sense of what I say through the irritable bowel. So just my first slide here is just a disclosure slide. And you can see here that I have no funding from commercial interests. I have a number of public funding sources fund my research. I sometimes get consulting fees as an expert witness and reports for the plaintiff in class actions against pharmaceutical companies, but any fees from this work are donated to an independent patient drug side effect information and reporting website, risk.org. So we are talking today about a big drug problem for Canada, and it's not the drug problem that we've been reading about a lot in the media, but I think it's an equally big drug problem that probably represents the biggest opportunity we have to improve medical care in older age here in Canada in the next 30 years. Meet Anne. Anne is 85 and she's had a fall at home. And Anne will be very familiar to all of us. You can see her medications there on the right. And we, our patients or our parents, often have scenarios like these where they have to take multiple pills at multiple times of the day. And a blister pack or a dosette is often used to try and reduce the confusion and keep things on the track. But why is this a problem? Surely if you need the pills, you need the pills. These are good drugs that represent the advances in medical science, surely. Well, it's a bit like music. If we listen to perhaps some Bach or some Miles Davis or some Leonard Cohen, the Four Tops or the Boss, Bruce Springsteen, on their own, they sound good and they do us good, they make us feel better. But if we play them all together at the same time, they become a cacophony. And this can be what it's like for patients when they're taking multiple medicines at the same time. And we know that this is a problem. This is an uncomfortable fact. In Europe, where we have the best data, more people die of adverse drug effects each year than die of colon cancer or breast cancer or prostate cancer. It's the equivalent of more than 2 jumbo jets crashing every day and killing everybody on board. If this was an airline, would you fly on it? If this was an airline, the fleet would be grounded until the system errors were sorted out. But patients fly on this airline every day. This cause of death and illness is largely lost in the focus on epidemics of disease or the need to treat risk factors. But in Canada, we know that over 1 in 10 people on 5 or more medications have a drug side effect that requires medical care. This is invisible in all our measures of care, yet this causes often more harm than many of the diseases the drugs are designed to treat. These adverse effects on patients are higher in residential care settings. We know now that in the US, more people are admitted to hospital from hypoglycemia, from the drugs used to treat diabetes, than from hyperglycemia, from the diabetes itself. We know if a person is taking an antihypertensive medication, they're much more likely to suffer a serious injury from a fall than their neighbour who is not. The rate of these adverse effects increase sharply with the number of medications taken. And there are other effects of polypharmacy. Polypharmacy is associated with quite specific problems that makes people dizzy, drowsy and dull thinking. And this has obvious implications for community mobility and social isolation. We see exactly the same things in the models, animal models of polypharmacy, where on their own medications aren't a problem, but when they're combined, the animals start to have impaired mobility, balance and strength, as well as cognitive difficulties. And it isn't just wasteful in terms of the harms that these have, it's also wasteful in terms of effectiveness, because sometimes, as you can see on the right, it's almost impossible for a patient to take all their medications, and that in the chaos it's possible that the pills that get missed may be the ones that might be of most benefit to that particular individual. So how do we get to this situation? Well, here's a well-known analysis from 2005 by Cynthia Boyd of the way in which our single disease-focused approach to giving medications in older age makes polypharmacy almost inevitable. We take a woman of age 70 and give her on average what that a woman age 70 might have, which is 5 chronic conditions, 2 of which are giving her active symptoms, her arthritis and her COPD, that stop her from going dancing the way that she used to and interacting with her grandchildren in the way that she'd like to, and 3 others that are risk factors that I, as a good doctor, have measured and told her about. And if we apply the guidelines to each of these single conditions, it'll be no surprise probably to any of you what happens next. She'll end up on 19 doses of 12 different medicines taken at 5 times during the day. She'll also be, we'll ask her to engage in 14 non-pharmacological activities, which take up a significant amount of her most precious commodity, which is time. And in fact, I updated this interaction list last year, and since the original publication in 2005, there are now 16 different possibilities for significant medicine interactions, either with other medicines or with other diseases. So you can see here that this single disease-focused approach to care, while the doctor who prescribes in this way might look measurably better in terms of performance, but this will result in meaningfully worse care for this individual patient. So for good medicine that's good for your health, you need good clinicians, because while prescribers are what turns chemicals into medicines, a wise, person-focused generalist prescriber is what turns them into good medicines. Like tidying up music into its component parts, this is what happens when we tidy up patients into their component diseases or drugs. The loss of meaning or context makes it impossible to hear the melodies of the patient's life and to provide care that will enhance it. So, leaping into the void, how do we address this? We've done work with both patients and doctors here in Canada and in New Zealand, and this is what patients say, that both patients and clinicians are afraid. Patients say, well, we'd like to take less medication, and we think you doctors probably prescribe too much. We think stopping pills now and then, a drug holiday, is a good idea. But we don't start conversations about this as we worry about what you'll think, and we want to be able to restart a drug if we try stopping it and we think that we're better off on it. Doctors said, well, we worry about giving the wrong impression by starting the conversation. We worry about the lack of a system approach to stopping medicines and guidance, and we worry about not following these single disease guidelines and being counted as a poorer doctor. So how do we open the conversation? And here's just some suggestions for ways to open this conversation about medications. So the first is to perhaps use a metaphor like the music metaphor that I described to you before, but a way of highlighting that, in fact, not all medicines get along, that on their own medicines can be helpful, but combined together they can cause problems, and there's a need, therefore, for individualised tailoring for each and every patient. The way that older bodies respond to diseases and risk factors and process medications changes, so there's a need to review whether medications are still of value and whether they might be causing harms that we're not realising, and that targets for treatment are different as you get older. That in most medications, we should probably be lowering the dose at least to avoid side effects with ageing while still achieving the same benefit, because our body processes medications and cells respond to them in different ways as we get older, and that the evidence for effectiveness changes with aging. It's also a good opportunity to review what the goals of treatment are, because they may change for people as their end of their life gets closer. So we know that there are a number of tools to try and help with approaches to polypharmacy. Many of them will be familiar to you, the Beers criteria, stop criteria, anticholinergic burden. And these are a drug-based approach. So these are what's called explicit approaches to polypharmacy, where lists of potentially inappropriate medicines are created. And these lists can be very helpful tools. However, it's also possible to be on 12 concurrent medications and have none of these on these lists. They only predict around a quarter of hospital admissions due to drug side effects. And so, like disease-based care, they still map awkwardly onto primary care, They're not responsive to the complexity and heterogeneity of the patient with multimorbidity, and nor to the individual patient's priorities. But this really emphasises the need to review the medications of all older adults with an eye to deprescribing, particularly those who are vulnerable to the adverse effects of medication, and to consider each and every medication for potential withdrawal, extending just beyond these standardised lists. Most patients we know from a study just published by Emily Reeve, most patients, if asked, would like to take less medicines and would relish the opportunity to have this conversation. And just an easy way to start is to say, I see you're on 14 drugs. Would you like to review these together to see if we can reduce these? It's really important, most important, for clinicians to develop excellent skills in prioritisation and understanding what makes a life worth living for that individual patient, because the answer to this is as variable as it is in individuals. And you can see here in this quote from Sir Theodore Fox, who was an editor of The Lancet, it really articulates it beautifully. Not least do people differ in the attitude to life. Some cling to it as a miser to his money and to his little purpose, whereas others wear it lightheartedly, ready to risk it for a cause, a hope, a song, the wind in their face. But so many people think of it as a means. The doctor surely would be wrong to insist that it's always the first of ends. Life is not always the most important thing in life. So decisions in older complex patients should routinely consider expected survival and quality of life, giving the highest priority to what matters to that patient and to their family. Before initiating a potentially appropriate medication, we should always consider the validity of the evidence in this patient based on their characteristics and their priorities and preferences for care. And it's important to employ mixed implicit and explicit approaches. So the explicit tools are helpful, but we know from research that elderly people have different priorities from us as health professionals, and that if we just rely on our epidemiological knowledge to guide our inquiries about unmet needs and what's important to patients, we may find that what we perceive as important is disconnected for what's important to the patient. Understanding patient priorities is an essential skill for us as excellent clinicians. And as you saw in the example, while 18 medicines may be recommended, in order to ensure that they don't collectively do more than harm and good, it becomes necessary to prioritise in order to tailor these to support what the patient wants from their treatment. Implicit approaches take into consideration the research data on potentially inappropriate medicines. They combine that with effectiveness and safety that's relevant to the age and context of the patient, but also consider clinical circumstances, the other morbidities and drugs that the patient's taken, and the patient and family preferences. Implicit approaches are less algorithmic, and they require more time, knowledge, and judgment. But this more complex approach is much better suited to multimorbidity and to a shared decision-making model. So how do we open that conversation about priorities? Well, again, we went to patients and ran some focus groups to say, what are the important areas to be articulated in this kind of conversation? And in conversations with these groups of patients in New Zealand and Canada, this is what they told us. This is what we need to understand from them about what they need from medicines. What are the things they'd like to be able to do that their health stops them from doing? So what are the functional things that we can maybe help and support with treatments? Which symptoms do they most want help with from their medications? And what don't they feel they need treatment for? How important is it to them to have treatments that try to prevent future illness versus the ones that treat current symptoms? And sometimes you can find a metaphor for doing this. One useful thing is to say, well, if I have in one hand a red pill and the other hand a blue pill, the red pill is to prevent future illness and the blue pill is to treat current symptoms that you have. If you rate out of 10 how important each of these would be to you. And that gives us a helpful insight into priorities. Patients Patients are keen to be involved in partners in their care, as you've seen, to be engaged. And these are the important domains to ask them about when we're trying to together prioritise their medicine list. We need to know which medicines they want to stop the most, and that's quite helpful often in revealing side effects and interactions, which medicines aren't getting along, which medicines they think is the most valuable to them, and do they take the medicines in any ways that are more helpful to them in the instructions, and this may highlight problems in taking some of the medicines. So how do we tame these monsters of polypharmacy in our office practice? Sometimes when faced with a patient on 20 medicines, it can be impossible to know where to start. So here's some suggestions of ways to begin the process of ensuring that we reduce drug interactions in polypharmacy. Communication and collaboration with patients is the essential first step, and shared decision-making can really inform that conversation. An approach that uses a kind of the idea of a drug holiday or pause and monitor is useful as well, and is often an appealing choice to begin. So perhaps we pause this drug for a little while and together we monitor how you feel on it and off it, and then make a decision on whether that's really useful to you. You can start by perhaps choosing a side effect or burden. Focus on one particular side effect across all medications, for example, the anticholinergic effects, or the serotonin burden, or the burden of drugs that lower blood pressure. Or you could focus on revising prescribing cascades. Look at all patients who are taking anti-inflammatory drugs and look to see, do they have raised blood pressure, or are they on treatment for high blood pressure? I've had a number of patients where in switching from an anti-inflammatory to a Tylenol for regular pain relief, we've actually been able to stop their antihypertensives. It was just a prescribing cascade from the anti-inflammatory. These are examples of problematic cumulative burdens which can be useful to focus on. The two at the bottom I put arrows next to are the most common causes of admission to hospital with adverse drug events, hemorrhage and hypotension and falls. Serotonin burden is often under-recognised because it can present with agitation or confusion, things that can often be mistaken for other things in older adults. So these are useful ways to take a first step into looking at deprescribing. The next way you could start is to choose a particular problem to always think about deprescribing. So perhaps choose patients who present with falls or cognitive impairment, and then choose as your first question, is this problem caused by drugs? Or another way in is to look at what's called legacy prescribing. So medications that are started for usually an intermediate duration, longer than, say, an antibiotic prescription, but they're not a life sentence. So drug groups like proton pump inhibitors, SSRIs, bisphosphonates or benzodiazepines. Can you look at your prescribing system to modify them to flag when the course of intended treatment is complete and make sure they're stopped appropriately? Or can you modify the initial discussion to set expectations when you start? We know from work that we've done in Canada that about half of patients who are taking these medications are prescribed them for longer than the intended course length. So this is fertile ground for improving practice. Or you can choose specific medications to focus on which may cause problems in older age. Beta blockers is one example. They're drugs that aren't helpful for hypertension in older age, and also should only be prescribed for between 1 and 3 years after a cardiac enter a stent, but often aren't discontinued appropriately and do cause significant problems. Or you could choose 1 or 2 patients in a day with whom to start a deprescribing conversation. So just moving to how to stop or tapering. Pausing and monitoring is a good way to frame it, and just starting with a simple dose reduction can be a useful way in. I tend to taper as a rule. Stopping medicines is a very gentle art, and as evidenced by the SSRI antidepressant medication, often we don't realise until much later in a drug's life on the market that we do need to taper it. They can cause withdrawal symptoms. for example, in decreasing beta blockers, antihypertensives, sometimes there could be an increase in heart rate, and that can be quite uncomfortable for the patient. It's important to talk about the anticipated discontinuation effects and reassure them, and also give red flags for any important reasons why they should contact you. For example, in stopping a beta blocker, to contact the clinic if they start to develop chest pain. To discuss monitoring, who's going to monitor, what you're going to monitor and how often, and when they should come back to you to have a discussion on whether this is going to be a permanent discontinuation. And to discuss between you to have an agreement on when you might consider restarting the drug. So when patients have multimorbidity, the single disease model and its incentivisation should be spurned. Variation in care has become a kind of dirty word that implies variable quality. But some variation, as you can see, is a healthy, essential and excellent practice in translating the partial statistical lives of trial participants into person-focused care in the real lives of patients who provide health care that's best for them, and being led by patient priorities, but integrating that with medical knowledge. And there are some real policy opportunities here to improve the quality of medicine use in polypharmacy by addressing some of the structural barriers. Firstly, in thinking about how we can have quality measures and funding that value the art of not doing, to incentivise review processes aimed at reducing treatment burden as a routine preventive activity for us in primary care. And to think about how we can incorporate into medical training generalist approaches to polypharmacy and multimorbidity, and to how to include and make visible prioritisation skills and approaches to stopping medicines as well as starting them. Addressing polypharmacy is a team sport, and I know our next speaker is going to talk about the importance of that. And in this case, the team is the patient, the pharmacist, and the doctor. We're testing this model called a team approach to polypharmacy evaluation reduction, or TAPER, here at McMaster, in a clinical pathway that we hope is suitable for use as routine prevention in primary care. So, in conclusion, polypharmacy carries really significant morbidity and mortality as well as treatment burden, and most patients will be happy to have a conversation about reducing polypharmacy. We just have to open that door. And these are, it's really such an opportunity, these problems in our system, these cracks in our way of caring for patients with multimorbidity. As I said, I think opportunity is the greatest window to advance patient care for older adults over the next 30 years. Because as Leonard Cohen famously said, there is a crack in everything, but it's how the light gets in. So thank you for the opportunity to talk today, and I'm really happy to take any questions that you have or comments.
Excellent. Thank you so much, Dr. Mangin. That was a fantastic presentation. I know that we do have to let you go right away. You only have until 1:30, but I did have a question from the floor that I'd love you to take the time to address. Maria Thibodeau did ask, when dealing with mental health illness, oftentimes several medications are used for the various effects of mental health symptoms, for example, inability to focus or depressive thoughts, etc. What are your thoughts considering this possibility, especially when we add aging into the factor?
I think that's a really great question. In fact, some of my most successful deprescribing has been mental health medications. And I think this is a situation where often patients get started on drugs, other ones get added, and then they just get continued indefinitely. And I think the first thing that you can do, after talking with the patient and their family about their priorities for what they want the medications to help with, is to look when someone is on a group of mental health medications and look to see if there are prescribing cascades in there. Is there, for example, a medication that can cause agitation as a side effect, for example, an SSRI, and are they being prescribed a medication for sleep or something that depresses that agitation? We looked in one study in New Zealand at patients who were being prescribed venlafaxine, and we found that at least 10% of those patients were being prescribed a low dose of quetiapine in the evening, probably to reduce the agitation as a side effect. So that would be the first thing that I would do in approaching polypharmacy in mental health patients. And the next point that I would make is to, as with all medications, to very gently taper and to keep regular conversation with the patient about how they're feeling as you're discontinuing those medications. We know that I know that with any psychoactive drug, I always taper, and I taper gently, and I always let the patient be involved in determining what that rate of taper is, what they're comfortable with.
Excellent. That's a terrific answer. We always put patients first and foremost when we're talking about patient safety here as well. So I'm glad to hear that you are involving the patient voice in there. I know I have to let you go, but do you have time for just one more question here, Dr. Mangin?
Yes, certainly. I've got another 5 minutes.
Oh, perfect. Could you just address the medico-legal implications of deprescribing? Are there legal aspects that we should be considering when we're approaching this?
Yes, certainly. And the CPMA have written a little about this. And so the key thing is there are only 2 medico-legal requirements when you're deprescribing. And when you're varying your care from what the single disease guidelines for younger adults might say. The first requirement is the standard of reasonableness. So is what you're doing reasonable? So that what are your thought processes about why you're stopping? You know, what factors have been taken into account, and has the patient's view been both sought and recorded or incorporated in the decision making? And the second requirement is there evidence of this? So prescribers are particularly focused on complaints, medico-legal complaints. And what will happen when there's a complaint is that the first thing that will be looked at is the medical record. So that carries the most weight when assessing a deprescribing decision when there may have been a complaint. And so it's very important to put down your intellectual footprint in your notes to record what those thinking processes were in making that reasonable decision.
Perfect. Thank you so much. Thank you again, Dr. Mangin, for your time and your insights. We will collect the remaining questions and send them on for your consideration, and we can include maybe a follow-up later. We know we have to let you go now, so take care, and we'll really hope to see you again soon. Thank you again.
Thanks for the opportunity.
You bet. Now, I would like to invite one of the sponsors of Canadian Patient Safety Week up to speak. As Vice President of Pharmacy Services at HealthPro, Christine Donaldson leads the procurement of pharmaceuticals on behalf of more than 800 hospitals across the country. Prior to joining HealthPro, Christine was the Director of Pharmacy for 2 acute care hospital sites in Ontario, as well as specialized outpatient pharmacies. Please welcome Christine Donaldson.
Good afternoon, everyone, or good morning if you're joining us from the West. My name is Christine Donaldson. I'm the Vice President of Pharmacy Services at HealthPro, and we're honored today to sponsor Canadian Patient Safety Week and have an opportunity to speak with you on today's podcast. For those of you who may not be familiar, HealthPro is a national group purchasing organization representing the purchasing interests of more than 800 hospitals across Canada. I have very much appreciated this discussion so far, and it's certainly an area that was a big focus for me in my prior role. I'll just tell you a little story about that. We had a team of pharmacists and technicians who perform medication reconciliation and often identified many duplicate therapies. And they would look for discontinuations or perhaps therapies that had been on someone's profile for far too long. I remember one elderly patient in particular. And she had a very impressive list of herbals and all kinds of necessary medications as well that were treating her thyroid condition and also her hypertension. Unfortunately, she treated all her meds exactly the same and would sample a few different ones randomly each day. She didn't really want to be popping too many pills each day and instead would never follow the directions as prescribed. Clearly, she had an opportunity to simplify her regimen so she could manage her health better. Today, in my role with HealthPro, I work with pharmacists from across the country to put national medication contracts in place to also improve medication safety within hospitals to help keep patients safe. And now, I'll tell you about a particular area that I thought you would find interesting, which is advocating for fit-for-purpose products. I'll tell you exactly what that is and why it's so critical to medication safety. A fit-for-purpose product is just like it sounds, having the right product for the right purpose. Sounds so simple, but in so many cases, when a hospital pharmacy department issues a medication to a nursing unit, often that medication is not in the format that needs to be administered to the patient. The medication in a control pack, for example, needs to be popped out. And the nurse might walk over with the tablet over to the bedside, having no name, no lot number, no expiry, and nothing to barcode scan. Or an ampule or vial needs to be drawn up into a syringe. Any liquid medication also needs to be measured out exactly to the patient dose and taken to the bedside. Narcotic drugs need to be split into smaller doses as they are often too high for pediatric or elderly patients. So you can see there's often a huge gap in what is provided by the manufacturer and what is actually required by hospital staff to safely administer drugs accurately to the patient. How could this be? Well, manufacturers often produce medications primarily for the community, and in this setting, the formats are actually perfectly fine, but that's not the case for hospitals, and manufacturers were largely aware of this fact. We knew we needed to change that. So we invited over 70 pharmacy manufacturers to meet with our members from our hospitals all together in one room. We discussed these issues and showed them videos depicting exactly how not having the proper format to administer to patients can actually cause major medication safety concerns. We are now happy to report that we have advocated to bring many of the new fit-for-purpose medications to the market. As many of you know, the journey to bring new drugs to the market is very long, but we're already seeing a lot of traction. So far, our manufacturers have introduced a number of products, half-dose tablets like Zopiclone, or NIOSH drugs in a unit dose format. These are doing a far better job in meeting those needs of hospital patients and making the system safer to free up resources for hospitals to spend their time on other high-value tasks like tackling polypharmacy. If you're interested, we encourage you to visit our website on your screen right now, where you can view those videos that we've just talked about in a series that we produced on this medication safety topic. Thank you very much for this opportunity, and I believe we have another great speaker up next.
Excellent. Well, thank you so much for that, Christine. I really appreciate the time that you spent with us, and thank you so much for your sponsorship as well. Now we're going to actually invite Sandra Hanna to present on the value of interprofessional collaboration within the circle of care to provide patients with the best access to care and support. Sandra Hanna is the Vice President of Pharmacy Affairs at Neighbourhood Pharmacy Association of Canada and the Chief Innovation Officer at Gold Links Health Solutions. Sandra is also a pharmacist, a pharmacy owner-operator, and a consultant in areas of pharmacy operations and professional practice. She has spent over 10 years working in and managing operations at community pharmacy and became part owner in an independent pharmacy in 2013. She is passionate about advancing pharmacy practice, improving workflow efficiencies, and exploring novel ways to deliver enhanced value and care to patients in a multidisciplinary, collaborative practice environment. She is a thought leader with expertise in pharmacy practice and operations, and her recent interviews include CBC Metro Morning Radio Show discussing the opioid crisis. Sandra Hanna, welcome so much to our webinar.
Thank you so much. I really appreciate the opportunity to present to you all today and to be a part of this amazing initiative brought by Canadian Patient Safety Institute. So, just a little background, in addition to the wonderful introduction that you just heard. I'm currently the Vice President of Pharmacy Affairs at Neighbourhood Pharmacy Association of Canada. And for those of you who aren't familiar with the association, we're a national association that represents the delivery of care through community in pharmacy in communities across Canada. So we represent the majority of the known and respected brands and pharmacy providers across the country in several different formats, both retail, grocery, larger format stores, specialty pharmacy, and in long-term care, nursing home care. So, I looked at the patient safety website this morning and saw this caption this contest, and I thought to myself, well, what would be a good way to start this conversation? And the number of times I have heard from my patients, don't worry, it's natural. I've got these medications, but they're natural, so I'm not too worried. And I guess the real challenge here is that not all meds get along, and whether they're natural or not, whether they seem safe or not, whether they seem like they may cause a problem or not, not all meds get along, and it's really important to ensure that we're able to look at all those medications together and that we're able to address these issues as a team through pharmacy and physicians and other allied health. And pharmacy's really been trained, pharmacists are trained to use specific techniques and motivational interviewing to elicit and gather some of that really important information from patients, because what we often find is that we're limited to the information that patients give us. Patients are known to be poor historians at times, and sometimes they're really interested in pleasing their healthcare providers and making sure that they come across as the best patient, which we can all be guilty of as well. So, I think it's an art by pharmacists, by also other healthcare providers, to elicit the right information and ask the right questions to get the information that's most pertinent to answering some of those questions and being able to help patients achieve some of their goals. So, what are we really concerned about? And I know Dee mentioned it earlier in her presentation. The magnitude of the problem is massive. It is a real issue, and it's the number of people that are affected or lose their lives because of adverse drug reactions or medication incidents is the quantity of people, or the number of people that would fill 2 jumbo jets. So this is a huge issue. And really what we're concerned about is a number of different things when we talk about patients' medications. We're looking at medication interactions, so drug-to-drug interactions, and that could be a number of different things. It could be prescription drugs, natural health products, vitamins, supplements, over-the-counter products, and then there's also other substance use and alcohol. And most recently, which will start to become much more evident, is cannabis use now that it's been legalized. So, those are the obvious interactions we're looking for when we talk about not all meds get along. But we also have to look at drug-to-disease interactions. Not all drugs get along with all people. So not necessarily that drugs don't get along with other drugs, but not all drugs get along with the people that are taking them. There are a number of contraindications. And, beyond that, there's adherence. So, it's one thing when we talk about medications being taken the way they're meant to be taken, but a number of patients don't take their medications the way they're meant to be taken. So we have the issue of non-adherence and non-persistence. So the difference between those two is taking a medication in a way that's not intended to be the way that it should be taken, so that's non-adherence. Non-persistence is the case where, and I believe one of the previous speakers mentioned, just stopping a medication when you feel like it, whether it's because you don't feel like taking it one day, or whether it's because you feel that your symptoms have resolved. So those are 2 really big issues as well. And lastly, and extremely pertinent in the opioid crisis context, is diversion. So these are all, these are all things that can lead to medication incidents and adverse drug reactions in patients. So just a few sobering facts, in addition to the two jumbo jets facts that Dee shared with us earlier. Up to 25% of hospitalizations are drug-related. About 2/3 of drug-related hospital admissions are adverse drug reactions. When it comes to non-adherence, 50% of patients are non-adherent to their medications, and 1 in 3 initial prescriptions is never filled. So we start to understand, that it's one part of the story when we can talk about managing a patient's condition. It's one part of the story. So our first step is determining, what is this patient suffering from and what is the appropriate course of therapy. But it's a whole other story to ensure that we're appropriately managing their medication, not only from the standpoint of ensuring that they're taking their medications as prescribed or they're taking the right medications at the right doses, but also to ensure that those medications all work in the context of both the conditions the patients are suffering from, but also the other medications that they might be using. So where do we feel pharmacy can fit into this? So at Neighbourhood Pharmacy Association of Canada, we're advocating for a collaborative approach to patient care and the delivery of accessible patient care, and we feel that pharmacy is an important part of that. This is a team approach, as Dee mentioned earlier. It's an approach that requires pharmacy, physicians, and other allied help, and it requires that every healthcare provider bring to the table their area of expertise and maximize their scope of expertise and work together collaboratively to the interest of the patients and to help patients achieve their goals. Where we feel pharmacy can play a role is in primary care, so in helping screen and helping to provide initial screening services and triage services, drug optimization and medication management, obviously, and then public health and harm reduction. So today I'm going to focus primarily on drug optimization and medication management. So sometimes people ask, what do you do back there in the pharmacy or in the dispensary? A lot of people reference the old Seinfeld skit where Jerry Seinfeld says, well, what is my pharmacist doing up there? He's taking all the pills and moving them from the big bottle into the small bottle. And while that is part of the story, there is so much more that happens behind the scenes and that a lot of people aren't quite aware of. So when we talk about dispensing a prescription, why does it take more than 5 minutes? Well, in the background, pharmacists are performing certain technical aspects of the prescription filling, and that's the adjudication, ensuring that it gets covered by drug plans, maintaining and updating a medication profile for each patient, making sure that it's accurate and up to date so that it can be shared with other healthcare providers. And then they do the whole taking the pills from the big bottle and putting it in the small bottle. But then on the clinical side, they're reviewing each of these prescriptions. Every single prescription, new or refill, comes in and has to be tested against the entire medication profile to ensure that nothing has changed, to ensure that there are no drug interactions, to ensure there are no contraindications, and, questions with the patient to understand what other medications are they taking, what over-the-counter medications, herbal, supplement, natural products. Are there any interactions there? Are there any alternatives to the new medication that's been prescribed? And similarly, are there any complementary medications? Is a patient being prescribed a medication that might benefit from, a calcium supplement, for example? And then looking at whether that medication is indicated for that condition. And this is really, getting a second set of eyes on that prescription and working together to ensure that we haven't missed anything, because there are a lot of questions to be asked to determine the appropriate course of therapy and to engage the patient in that course of therapy. So it's really about having another conversation with the patient where we can reinforce one another's messages to help the patient be more engaged in their therapy and to help the patient be more knowledgeable about their therapy, to know what questions to ask, to know what to look for, to know what to expect out of their therapy, to manage expectations. Is it, in the case of pain, are we looking for full resolution, or is there a specific management of expectations that needs to happen? So those are some of the things that happen when we quote-unquote dispense a prescription. So, with all of that going on in the background, it's no wonder that patients are confused. They're dealing with a number of different healthcare providers, and I've written here that the circle of care, maybe it should be better titled sources of information, maybe it should be better titled circle of care, or individuals, trying to influence patients' care, but really there's so many different providers that are managing patients' care. So we have physicians, we have allied health, pharmacy, home care, hospital if the patient has been admitted or discharged from hospital. But nowadays we're seeing more and more that family and caregivers are a very important source of information to patients. But also, unfortunately, friends and Google are a very important source of information. And, I say unfortunately, but I think it's a great, great thing that patients have access to all this information. The challenge becomes interpreting and making sense of it all. And that's where patients really need to rely on us. Patients really need to rely on their pharmacists and their physicians to help interpret and manage that information. Because in the absence of somebody to manage that information, the information can be very overwhelming and oftentimes not even really relevant to patients. And we see all the time patients decide to discontinue medications on their own accord because of something they've read on the internet or because of something they've heard from their friends, or starting new medications because of something they've read on the internet or heard from their friends. And while sometimes those may be appropriate or relevant, it's really important to look at all those decisions in the context of the entire patient profile and the entire patient condition. So what other pharmacy services are provided? So we talked about dispensing. Medication management and care plans is another really big piece of what pharmacists will do for their patients, and we're going to talk a little bit more about that in a moment. But this is one of the huge opportunities, I think, that we have to help our patients gather a lot of information from our patients and also partner to share that information, because there is a wealth of information that we can receive in the community that because of our accessibility in the pharmacy and because of the time that we have with patients in the pharmacy, we are able to receive a lot of that information and be able to share and share it back with the physician and the prescribers to ensure that each of us is working with a full set of information to make the best decisions for our patients. So, with that medication management, it could be just observing patients in the community with other patients. A really simple example is I was working with an opioid, a patient who was taking opioids and being prescribed opioid addiction treatment by a prescriber that I worked very closely with. And we saw the patient in the community with other patients diverting medication. So, that type of information, unfortunately, is not as visible to the physician, but it's something that we see pretty often in the pharmacy, and we can share that information with prescribers to ensure that we're all working with a full set of information to help us make the best decisions. Prescribing, pharmacists are also doing a lot of prescribing, whether it's renewing for chronic meds to ensure continuity of care, or whether in certain provinces they can initiate prescriptions or adapt prescriptions in cases where, we are doing medication management and acknowledge that there might need to be an increase or a decrease in doses, and also in scenarios of tapering, as Dee mentioned earlier. And these are always done in collaboration with a physician. And different pharmacies and physicians will work together slightly differently. And it's important that different healthcare providers determine the process by which they're going to work through some of these issues and they're going to implement some of these services. So moving along here, I'm not going to spend much time on this slide, but really this sort of gives an outline of the types of services that different pharmacies can provide in different provinces. It's obviously very small and it's difficult to read, but I would encourage you to, if you're interested, to see in your province what types of services pharmacists can provide. The Canadian Pharmacists Association has developed a great tool that really summarizes the services pharmacists can provide per province. So when we look again at this not all meds get along, I think our goal really is to educate our patients to never assume that a medication is not harmful or that it will get along, but to always ask, is this medication okay? Do I belong here? Does this medication belong? Does it get along with my other medications? And to ask that question not only of their physician, but of their pharmacist every time. So what we would do to do that is we'd make a best possible medication history. Now, this is great practice in general for each patient. I usually recommend that patients will have their best possible medication records or history, at least once a year, and encourage them to update it every single time they have a new prescription added to their record, or if they have any changes in doses or discontinuations of any medications. And this really goes above and beyond the prescription profile because, depending on the provinces that you're in, you may have access to, an electronic medical record, but this really goes beyond that because it really includes not only what is prescribed and what has been dispensed for the patient, but it includes how are they actually taking it. And Dee mentioned earlier, we learn to ask patients how they're actually taking medications because we start to identify some issues, either that the prescribed dose or frequency is not working, and that we might need to make some revisions to the therapy, or we might determine that a patient's not taking these medications at all, and this happens extremely frequently. So if we rely only on a medication profile and a health record, patients could be hospitalized, and nobody would ever know how they're actually taking their medications. And we often see a lot of errors happen and a lot of adverse drug reactions happen because patients are then in hospital given the medications that they've been prescribed, but they haven't been taking those medications that way all along. So we usually recommend a best possible medication history be done annually at least with any medication changes before and after hospital admission and in any transitions of care. So if you're referring a patient to a specialist, great opportunity to send them down to the pharmacy to have a medication review. Every pharmacy in every province provides this service, and it's a service that's for the most part covered under a patient's provincial drug plan. So it's an opportunity for you to ask patients to go down to their pharmacy even before they come to your physician routine physician visits, because it gives you all the information you need to work with before you actually assess that patient. And some of the questions that we ask, obviously, is it the right medication, the right dose, the right frequency? Are they taking it as prescribed? Why not? Are there opportunities to improve adherence? Potentially it's a blister pack or a dose set, as Dee referenced earlier today. Maybe it's medication synchronization. Maybe they're not taking their medications just because they feel they have too many medications. So this is really a way to engage patients and better understand what their concerns are in a one-on-one consultation and be able to understand what their goals are. If it's simply to take less medications, then if that's an important goal for the patient, that's something that we as their healthcare team need to address because that concern is never going to go away. So how do we work together to do this? I always recommend working together with the patient, obviously, to find the common goals. So working to find the goals of the patient and then determining the best approach for communication is one of the most important pieces. Neither healthcare providers should be working in isolation. I think this is what creates the most confusion for patients and what creates the silos in our healthcare system. It's best to discuss amongst yourselves between a pharmacist and physician, what's the best format of communication? How frequently do we want to do it? And is there a specific process? Maybe, for example, we're looking at a tapering regime, and so the pharmacist is going to take over the taper and communicate back to the physician every time the dose is changed. Maybe the physician is going to continue to do it, but the pharmacist is going to follow up with the patient, to ensure that the patient's responding appropriately. So there's a lot of different ways this can be done, but it should be discussed. And I'll just end with saying that all the clinical guidelines really do show that collaborative approach is most effective. So Dee mentioned the TAPER study earlier. I do a lot of work in opioid management. So the opioid guidelines, the chronic pain guidelines, the National Chronic Pain Guidelines. McMaster mentions the importance of collaborative approach. The acute pain guidelines that have just been released by Health Quality Ontario also mentions a collaborative approach. So really, I think it's really, really important for us to work together as a team and to understand, you know, and every relationship might work a little bit differently, but it's very important to bring that collaborative approach to patients, to bring them the best possible service and health outcomes. So that's all. I'm right on the hour, so hopefully we have a couple minutes for questions if there are any.
Perfect. Thank you so much, Sandra. I really appreciated that talk. That was terrific. If you have a couple of minutes to hold on and answer a couple of questions that came from the floor, that'd be terrific. But I do want to wrap up for any people who do have to leave right now. So we are at time, and I do want to respectfully thank Dr. Dee Mangin and Sandra Hanna for sharing your time and expertise, and thank, of course, all of you for taking the time to attend. We know how busy your day is, and we appreciate you choosing to spend time with the Canadian Patient Safety Institute. We will hold Sandra Hanna here hostage for a couple more minutes to answer a few questions, but please visit our website for a recorded version of the presentation that you heard today. It should be up in about a week, and we'll send registrants of CPSW notice about that. To help us increase awareness for patient safety this year, we do encourage you to visit us at asklistentalk.ca to participate in all of our events this week, including the virtual screening and Twitter Talk event of Falling Through the Cracks, Greg's Story, on Friday morning at 10 a.m. Mountain Daylight Time. While you are on the website, please help us by signing the House of Commons petition to push for plain language labeling on non-prescription medications and natural health products, just like Sandra was speaking about. Many consumers are unaware that over-the-counter drugs and natural health products can pose a risk for harm and must be used safely. Lastly, on November 7th, we will host an event for the Advisory Council on the Implementation of National Pharmacare. The Council wants to hear the public's opinion on what should be included in a national pharmacare strategy, and the event will take place at the Delta downtown Halifax from 6:30 to 8:30 p.m. You can register online on our website in the events section. Dr. Eric Hoskins, Chair of the Advisory Council, and members of the Council will be there to hear from the public. And they're looking forward to hearing your thoughts, and so are we. So, Sandra, I'm sorry for that little interruption there, but if you do have a couple of minutes, I do have some questions from the floor that you can address now.
Not a problem. Yeah, my pleasure.
Excellent.
Thank you very much for having me again.
Oh, you bet. Thank you so much for your words. We do have a question from Colleen Hicks that came in to ask for your comment. An expert lawyer told a large group of care providers that legally the circle of care does not exist and can get you into trouble due to privacy. You always need permission from the patient to share any info with any other care provider. Do you have any comments about that?
No, I think that's absolutely true. So I think that, you know, when we talk about collaboration, we need to engage the patient. The patient needs to be central to that discussion. So, you know, however we decide to move about that, I think it's important to engage the patient first and foremost and talk to the patient about why it's important to have different healthcare providers involved in achieving their goals. Ultimately, the number one priority is, what is your goal as a patient? Is it, you know, to discontinue a medication? Is it to be pain-free? Is it to, you know, Dee mentioned, what is a life worth living to you? So once you determine what that goal is, building out or detailing out what that plan looks like and how it's going to involve different healthcare providers, that is the consent you need. So absolutely, we wouldn't advise, you know, bringing in other providers into the discussion without the consent of the patient. But it's all part of the big plan, and absolutely, the patient needs to be central to determining what that plan looks like.
Perfect, and collect that consent, of course, at every stage.
Mm-hmm.
Perfect. I do have another question that came up from Natalie Borden. Technology, such as a drug information system, can help address some of the issues around sharing of data, e-prescribing, recording professional services, etc. Can you comment on how you see the DIS making management of patient safety easier?
Yeah, so this is a very interesting question. It's a great question because the technology and the DIS is a double-edged sword as well, because you know, in Ontario, for example, and every province is sort of in a different place here, but in Ontario, for example, we don't have access to all that information. And we wish we did, because we think it'll make everything so much easier and it'll solve all our problems. In Nova Scotia, for example, I was just out there speaking at a conference, and I heard from a number of pharmacists there that the DIS is actually complicating everything, because the information is there, but it's not necessarily reflective of the patient's actual medication history. So I think that it becomes one source of information. So a DIS becomes one source of information, but the patient still has to be the other source of information. And then, you know, in the pharmacy, we have our own health record, and at the physician's office, you have your own health record. So I think that ultimately you want to try and bring together all those different sources of information, because they all have a very important piece of the puzzle, but none of them have the entire piece of the puzzle. So for example, a DIS would have, you know, what medications have been prescribed. It might not have over-the-counter products or natural health products. It might not have how the patient's actually using it. So when you look at, when you work with a pharmacist, and a pharmacist can identify, well, yeah, you know, they filled their metformin, for example, 100 days ago, but it was only for 30-day supply. And when we actually spoke to them, we understood that they're actually taking it, you know, half a tablet a day instead of one tablet 3 times a day. So, you know, I think it's important to use these sources of information, and I think that technology is bringing us a lot of great strides forward, but it's still one source of information that has to be aligned with other sources of information if we want to get the full picture of what's really happening.
Perfect. Thank you so much, Sandra. I appreciate your comments on that. And now we will be able to let you go, because we are at time, and I thank all of you for staying on to listen to the questions to be answered by Sandra Hanna. And again, thank you, Sandra, and thanks to Dr. Dee Mangin for the time that they spent with us. Please, again, do visit us at asklistentalk.ca, and have a wonderful day, everyone. We hope to see you again soon.
Thank you.
Take care. Thank you.